Don't be shy about a pat on the bottom or a rub on the back or a holding hands or a sitting next to. The intimacy has to be there and be alive.
Because our bodies are changing so much, like physically, just the appearance, that also becomes such a mental block with sex.
Fantasy can also be an important tool for midlife women to use when they are in the midst or trying to focus to get to orgasm.
Because I do feel bad for the men in our lives. If we don't know how to navigate, like, how can they know?
I don't want to speak for all women, but we don't want to be feared. We want to find our voice and say, this is what's important to me.
There's a lot of shame and even resentment when your libido doesn't match your partner's libido.
For women, I think this is true, psychologists, emotional closeness leads to sexual closeness. You have emotional intimacy leads to sexual intimacy. For men, I think it's
the other way around. Yeah.
Where
physical intimacy leads to emotional intimacy. And you take something just as simple as couples counseling. That is the type of counseling that gets the most results the quickest.
Okay, so let me just say this. If you're in midlife in a long-term relationship, wondering what happened to your sex drive, or trying to keep connection alive while juggling a million things, this episode is for you. Today, I'm joined by a couple who not only live together, love together, and work together, but also talk publicly about all the things most people avoid in private. Dr. Kate White is a nationally recognized OBGYN, author, and unapologetic advocate for women's sexual health. Jay White is a licensed marriage and family therapist who helps couples navigate the real stuff: resentment, disconnection, intimacy, and communication. Together, they host the podcast Heads and Tails, where no topic is off limits, from fantasies and mismatched libidos to the truth about what happens behind closed doors in long-term partnerships. We're talking sex in midlife, emotional labor, bodies that are changing, desires that are evolving, and how to reclaim intimacy on your own terms. This one's bold, raw, and real. And if you're listening with earbuds in, you might want to turn the volume down just a little if you're in the carpool lane. Let's get into it. Welcome, Jay and Kate, to the Iconic Midlife. I'm so excited to have you guys today. How are you doing?
We're doing great. It's so nice to be on here with you and talk about all things menopause, perimenopause, relationships, sex, and hormones, and all those things.
Yes. Oh my God. It's like never ending. I feel like we step into midlife and we're kind of like, where's the roadmap? Like, where are we going? Like, are we jumping off here at this exit? Are we continuing on the freeway? Like, it is just this like tornado of things that happen, almost feels like all at once.
Well, Mario Kart, where the things will get.
Oh, you're trying not to get hit by people throwing.
Yes, yeah. Right, you're like driving along and it's all good, and all of a sudden,
like
a banana comes out at you.
Right. And you don't know with menopause, perimenopause, different things like you don't know if it's coming from the problems coming from within inside you or from life itself throwing something at you. So
right. I do feel like it's a mix of those things,
sure, because life doesn't stop.
That's right. It feels like our bodies are betraying us, a bit. And then you've got all of these external factors, your relationships, kids sometimes, work. It's like all these things are happening at once. But before we fully dive into that, I want to talk about you guys for a second, because what I find is fascinating is that not only do you guys have this amazing podcast, but you guys are married in real life. You work together, you podcast together, you had a great family together. So what came first? Was it the work and that's how you guys met each other, or you got married and then found a way to work together?
Working together, it was accidental, where we were doing completely different things, and we live what I like to say in a big small town in Charleston, and we noticed that we were seeing some of the same people, just because Kate would deliver them, and then I would see them
for gynecology, and then
mine for therapy or couples counseling or something like that, and they would come in and they say, "I have to tell you, your wife delivered my baby. We love her." And then it would be, and so, but we realized we're hearing the same, a lot of times the same complaints, but taking a different approach to it. So a psychological and a more
Medical.
medical approach. So that's kind of how that happened. It was on accident.
That's amazing. And you guys clearly have made it work. And it's, I was just listening to your podcast, actually, one of the latest sex episodes, which is like so what I want to talk about because as you can imagine, I'm getting messages and DMs and like just so many questions from midlife women out there who are just so confused by their body and the changes, not only just physically, but mentally and emotionally as it relates to sex. So, to kick it all off, if you could just kind of explain, because I feel like when I'm on this journey, especially with this podcast, I too am learning things about my body that I never knew before. And I feel like a lot of women are in the same boat. What is happening to our bodies biologically that affects our sex drive?
So when we look at any kind of sexual interaction, there's really three things at play. There's biology, and then so it's bio, psycho, social. So it's the biology, like how is my body responding to this input, and then there's the social part, which is do I have is this the appropriate time for us to respond, or do I have to go to take to someone to soccer practice, or and then there's the psychology part of, am I feeling really anxious and depressed, because that's going to shut down any desire to really have sex right now. So you have to look at these three prongs of this that all have to be able to align to have a sexual response. Because if any of them is off, that's going to derail your your desire for sex.
Correct. Yeah,
Thank you.
yeah. No, well, good. So talk about the what's happening physically.
Yeah, so absolutely. So when we look at the biology of the changes of midlife, you've got these follicles that may have an egg inside them, and you only have so many of them. You are given all that you have that you're ever going to have when you're born, and they gradually decrease, and they also gradually decrease in quality. So you've got the big drivers of hormonal drivers, the primary ones that fluctuate from your ovaries are estrogen and progesterone. And so each follicle that has an egg in it has cells around it that make estrogen, and your brain has estrogen receptors, and your estrogen receptors are, if they're empty, if they're going to send a signal to your pituitary and say, hey, we want more estrogen, and it sends follicle stimulating hormone to the ovary, and the ovary is supposed to respond by recruiting a follicle that has an egg in it, and all the cells around it will make estrogen. Well, that works great in your 30s and from about 15 to 35. But then as your ovaries age and your follicles become less responsive, you get your messages from your brain are like, oh wait, I really mean it. I really want that estrogen receptor, and your ovaries are like, and they're kind of slow to respond, and it's like, no, and it sends more follicle stimulating hormone, and then it's gradually recruiting all these semi poor quality follicles. But each of those follicles has cells around it that make estrogen, and the estrogen levels get higher and higher and higher. And so you go through these cycles where finally your ovary responds, and you've got these super high levels of estrogen. And is that a real problem? Your brain does pretty well with high estrogen. In fact, when you're pregnant, your hormone levels of estrogen a lot of times will be close to 1,000. But a normal cycle, they only get to be about 200, 300. So we do pretty well with high estrogen. What our brains do not like is when your estrogen plummets and comes down after you ovulate, and then you go from a nice arc of up and down with your hormones to this huge spike, and your brain is like, hey, wait, where'd that estrogen go? And that's when you start getting brain fog, and your dopamine and your serotonin are not controlling your cycle, and you're getting more anxiety because your serotonin is off, and you're getting more crazy loss of executive functioning where you feel like you have ADD all the time. And the worst thing about it in some ways is that it's so irregular and cyclic. And sometimes it's happening, but it and firing off, and you're hitting all your marks, and you're killing it at work, and you're remembering all the words all the time. And then the next day you will be feeling moody and irritable and can't remember any words and can't remember where you put anything. And that is a real sense of loss and urgency. And because you are no longer able to manage what you easily were able to manage previously.
And it's terrible because the husband or the kids or whatever will wonder, where did mom go? Or where did my partner go? Or something.
Yeah.
Like
so sorry, that was a long biology lesson, but that those big spikes are why you're starting to feel, because you're at your dopamine. Estrogen helps your dopamine, and dopamine is responsible for attention and activation. And when you lose it, you no longer are able to pay attention to the things and get the things done that you needed to do. And so when that happens, and you're already the person in the house that's responsible for or in work for so many things, and it's a lot to juggle all the time as being an adult and being an adult in this part of your life. And then when you lose that regulation and support in your brain, it is that you are feeling, and so you're feeling like you're out of control. And that biological part is going to impact your sexual function, because if you don't feel like you're in control and you feel like you're fighting a battle to get the rest of your life, you're not going to feel like that this is the time to reproduce.
Right. Psychologically, you will there's a it's called the Garcia effect, where that's where you have too much of something, and it either it makes you sick, or you had something and your body blames it,
like fuzzy navels. Yeah, that was very bad.
College, fuzzy navels.
Yes.
Everybody has something like that. You've seen people that say, I can't drink tequila anymore because I spent a night, or a day and a half throwing up over tequila. So this kicks in for couples, and where she is wondering, wait a minute, what is going on with me? It must be something in my life. And so that a lot of times the partner can, no, a lot of times the partner is to blame, but sometimes the partner can be blamed for something that's happening internally. I mean, because you'll see guys, and we're guilty of this, where guys will say, wait a minute, I haven't changed. I'm the same person I was, and you used to like these things that I did. You used to think that this was funny. You used to, and then all of a sudden that's not working anymore. And yeah. And so where do you go from there?
Yeah, where do you go from there? And I'm glad you're bringing up the partners, because I do feel bad for the men in our lives that don't really know if we don't know how to navigate, like how can they know, how to navigate these waters? And, I feel like, for example, my husband, he does the best he can, trying to see, but even he's kind of like, I don't know what I'm stepping into, he's like, he will like walk into a room, and if he thinks I'm in a bad mood, he'll be like tiptoeing back out, because he's like, I don't want to face the wrath,
Right. Yeah. Well, that's exactly right. And that's the cycle guys go through, where they start off with just trying to weather the storm, whatever it is that's happening. And then we will try to fix, of course, which sometimes goes quite poorly. And then you can fight. I mean, it'll just be, what is wrong with you? And no, what's wrong with you? And then it goes back and forth, and then nothing happens. And then, then it's the tiptoeing out of the back of the room.
And that loss, it's even loss of more connection and loss of more intimacy. And that, and no I wouldn't say, I don't want to speak for all women, but we don't want to be feared. We want to find our voice and say, this is what's important to me, but we don't want to be feared or resented. And so
Right.
it's trying to find that tipping point between taking that autonomy of saying, this is what's important to me, this is what I need, without screaming it. So that everyone shuts down.
Right.
So it's trying, and sometimes, and that self-regulation that you get. So your frontal cortex is the part of your brain that it allows you to say, this is the time to say this, or this is not the time to say this. And when you have hormones that are not firing correctly to stimulate that part of your brain, you lose that regulation. So people say, I lost my filter. And some of that is good because it clarifies what is important to you and what's not important to you.
Yeah, some things need to be dropped.
Yeah, there's some things that need to change. But if it's damaged, the point at which that loss of filter starts being damaging, that's where you have to say, okay, do I need something to even this out? Do I need to do, is it going to be mindfulness? Is it going to be meditation? Is it going to be possibly hormone therapy? And that's why a lot of people do end up going on SSRIs, which is not necessarily the bad thing but it's not necessarily where you have to start. And so I think that when we look at how many people get started on SSRIs at this point in which is things like Zoloft and Prozac, they're not wrong things, and they do help with the serotonin imbalance that we do have. But are there different ways to balance those things so that you have that, give you just that beat of time and control in so to not blow up your
Can I tell you about our fight last night?
Oh, yes, please tell me.
So we're sitting upstairs, and we had our own podcast today, and then we had your podcast, and we have different things going on today. And she's about to there's a lot of stress. She's about to take a test tomorrow.
A huge exam, yeah.
So at this point in her life, this is still taking tests.
Yeah.
And so I'm upstairs and watching on mute the end of the Phillies game, and I've been working all day and preparing and getting stuff to do, and well, not at your level, but she comes up. I mean, she comes upstairs, and obviously there's some tension and build up, and I'm just just watching the game, and she says, "Sure wish I had time to sit up and watch baseball." and I thought, wait a minute, what? When is it? And it was just being nervous about the test, and it was being nervous about all the things that we had to get done today. But boy, the filter was off. It was great.
It was. So, and I did go back, and I think that how do you, if you do have these times where things come out the way that I think that you don't necessarily in the best way, can you bring it back around?
Yes.
You have to be able to heal those moments too. And I think that that is where you can bring it back around to, and that's where investing in your intimacy in general, because intimacy leads that emotional connection for women. I think this is true, psychologists, emotional closeness leads to sexual closeness. You have emotional intimacy leads to sexual intimacy. For men, I think it's
the other way around. Yeah.
Where
physical intimacy leads to emotional intimacy. And so it's a great circle when it's working. And then when it's not, it's it can fall apart pretty fast. And I feel bad. There's all sorts of things that can go wrong, but certainly if physically you're not feeling like there's pain with sex or something like that, the guy can still feel rejected, and it's not him at all. I mean, it's and I don't mean it's not. I mean, he's certainly a part of the pair, but it's not as if, he can feel like, well, why is she mad at me, or why is she, and it's not that.
Or yeah.
That's just a simple example.
So yeah, when we get those hormone changes, and they can even start in perimenopause, which people don't realize, that you can start having some of that dryness, and vaginal dryness and irritation, and it can be cyclic. You can get it just when your estrogen drops with your period. And it's certainly okay to use lubricant at any time, but certainly using a lubricant can be helpful. Because if you do have pain, your desire center is going to shut down. It's going to be like, well, nope, we're not doing that. And so even using a little vaginal estrogen during that time can be helpful, because there's so many estrogen receptors in that area especially at that entrance to the vagina. And you can also get decreased sensation in the clitoris and a decreased bulk in the clitoris as your hormones change there. So adding back some estrogen even if you are on other hormone therapy, that can be very valuable and really helpful, because if the equipment doesn't work, then that's just a non-starter, right? So that is just adding that back. And then we have changes in estrogen, progesterone, testosterone. All of these things change the testosterone changes from 40% of men are have low testosterone in their 40s. And as those changes happen, that can affect their ability to feel desire or maintain erections, things like that. But it's important to address for both parties, because if you're so the pain, that's one part of it,
right?
And then it's just the emotional anxiety and depression that can happen. It increased about 30 to 40% in perimenopause.
Yeah, there's lots of different directions that you could go.
And then if you get
for your audience,
SSRI, then your sexual function gets even worse.
Goes even worse, yeah.
Right. And then the connection, I thought it was so interesting that you guys really talk about, how men and women are so different, especially with sex, like it's almost like two ships passing in the night. So if you don't have that connection, like, especially with all these things going on, what are like things that we could do to reestablish connection with our partners?
I think that's important.
Yeah. So in therapy, we talk. First of all, I always use the term intimacy, and not. Obviously, we talk about sex in therapy, but we use intimacy, and intimacy, as you say, intimacy starts in the kitchen. So it's the hand holding, it's the leaning in when they're talking, it's the pat on the bottom, it's the it's being interested in one another. So intimacy is something that can be going on all the time, rather than you're sitting upstairs watching a Western and then say, all right, let's get it on, and that doesn't
giddy up.
Giddy up. All right. So right. So that and that's the biggest thing, is if you ask what's the two biggest things are intimacy that should be going on all the time, and communication going on all the time. And there's all sorts of ways to mess those up, but to do those and to try those and to keep those alive, that's that would be the best advice I would.
And it means different.
Couples.
If we look at different things, you have to figuring out what is valuable to your partner. So you can say keep intimacy and connection alive, but it really has. And some of the things that I think there are structures for things like the 5 love languages. That's a really good place for people to start. Say, if you can't even think about what is important to your partner, you're like, I don't know what she wants. And she may not know what she wants. You can say, let's give some structure. Say, okay, how does she feel loved? Does she want gifts? Does she want you to acts of service? Like, does she just want you to do the laundry, and just give her one less thing to do? Can Can you tell that's mine? Could you just do something?
Totally.
Do a lot of things.
Yeah,
I accidentally sat down and watched baseball last night.
You're like, hint, hint.
Exactly.
Yeah.
That's right.
Yeah.
And there are people who it's physical touch, and in that physical touch can be that they want some physical touch that isn't necessarily associated with sex.
Right.
So they want that physical touch to be, I don't want to be, all the time I'll talk to patients and they'll say, well, I don't want my foot to touch his foot in bed, just in case he thinks that
Let's get
I
it on.
want to have sex. and that is a loss. That's such a loss in your relationship. If you feel like there's any overture is going to lead, maybe a signal that you are going to have sex, then you've lost a lot of the closeness that you had. And so that physical touch doesn't have to be an intimate in terms of sexual intimacy, but intimacy, it could be like when you were trying to tell someone that you liked them back in the day. You get closer, you walk with your hand in his back pocket. I'm sorry.
Girl.
That was from the mall when you're walking in the mall.
Totally.
And then
mall.
And
right.
but that so we've got gifts, which some people do. They have that gift, like bring her flowers, physical touch, acts of service,
quality
time. Be like, say,
just the main thing is to figure out which one you are.
Yeah. What was the last one?
I don't know. We'll do the four love language.
So yeah, but there are constructs that you can say, let's fill this paper out to figure it out. If you going to a couples therapist is great, but not accessible to everyone.
Mm-hmm.
But if you can figure out what that is and then say, okay, I'm going to concentrate on doing some of these things and investing in our relationship in that way, for both of you, so that you can say, okay, this is what's going to help to get this framework a little bit more solid.
And the moment you start working at it, it gets better.
Yeah, any step, it's like baby steps even. And, I feel like too, there's a lot of shame and even resentment when your libido doesn't match your partner's libido. It's also like one of those things where it's like you feel bad if, you don't want to have sex and he does, or vice versa, And so how do we kind of navigate those waters when they don't match?
You just get it on anyway.
That's what we've been doing, right? And so
that's what
we've been doing. No, that's what a lot of women are doing. Is
we as women, not we as a couple.
I'll say
this is TMI.
That's right. So that libido mismatch is so common, and I think it is again where you have to think of it as there's things that affect the hormonal part of that. And if you've ever done a diet like that's an elimination diet, like Sugar Busters or keto or something like that, at first when you cut out all sugar, let's say, that first couple of weeks, you're like, oh my God, I would kill for a Snickers. But then after you get to about 6 weeks, 8 weeks in, you're like, ooh, that just sounds gross to me. And the desire center of your brain is programmed that way. So you get all if you stop having sex whether it's you're just in a bad place emotionally, or you're having pain, or whatever reason you get more and more of this distance, your desire center is like, that seems like a lot of work and it's kind of messy. And it sounds like I would actually rather sleep because I'm not sleeping well. And so that all gets down regulated. So trying to reestablish that may take a lot more mindfulness, a little bit of sensate focus, trying to reconnect and do things where as a couple that are in the bedroom that aren't necessarily just put out there. This is tonight is not going to lead to sex. And
Yeah,
you
I
do that
say
with
I
couples
do that. I do that.
sometimes.
I do that a lot with couples where I will say, um, well, let me just back up one half step. So if you take kind of a triangle of women's health or and mental health, there's the physical health part of it, and there is and what goes along with that, of course, in menopause and so forth, are the estradiol and all the
Hormone change.
hormone changes and hormone replacement, and so forth, and whatever it is that helps you, breathing exercises, supplements, whatever helps. But then life keeps going. I mean, all the problems of the day, the bills still come in the mailbox. I mean, if you felt zero symptom from menopause, you would still have life coming at you. I mean, it's still going. So to find the to find the best combo of that, which keeps you going, and then yeah, communication. And I say to couples, I'll say, all right, here's what we're going to do this week. You can be as physically intimate as you want without sex. So you can hold hands, you can sit together, you can hold each other, you can shower together, you can do anything, you can do whatever you want, but no sex. And then we'll talk about it next week. And often they come back and they say, "Oh, we had sex all week." Yeah. And so part
Interesting.
of it,
Okay.
yeah. So part of it is that is okay. We took away the pressure. Now that doesn't, I shouldn't say work every day. I'm not trying to trick them or doing it, but if the problem has been pressure, that one libido is here and one's here, then that can often take that away. Or let's just take the pressure and just be together. Um, yeah, and then there's there's all sorts of other
And look at
things
the
that you can
and there are
do.
things, testosterone. There are, unfortunately for women, there are not very many medicines that actually can help in that neurotransmitter area of because our problem is not men have, there's desire, arousal, orgasm, resolution. So men,
That's the chart we all saw in the 7th grade.
yeah, like
Right. Health
Sixth
class.
class. Remember? Yeah, we all
the
had
PE
sex.
coach was teaching.
Right, the PE guy, right.
Yeah.
We had
So-
Mr. World. He was awesome.
Yeah,
Yeah.
and so and so for most men, they're already at desire like 80% of the day, if not more. And so, but the for women, their problem is typically arousal. So that whether it's erectile dysfunction, that they can't, it's a plumbing problem, and so they can take medicines that vasodilate the vessels of the penis, and then they're like, oh, look, I have a boner. Let's go. I mean, and our problem is I can't even get to, the
Desire.
starting line.
Right.
And so there are things that work, and testosterone is the only current FDA indication for testosterone in women is for hypoactive sexual desire, or decreased libido.
And that's hypoactive.
Hypo.
Right.
Like
not
low,
hyper.
low.
Right. Low active.
Low sexual desire. And so it's definitely a potent neurotransmitter. Now, there's all other kinds of things that testosterone does in other places, but the only other two medicines there are for hypoactive low libido in women are a medicine called Vyleesi, which is an injectable medicine. It's bremelanotide, and then there is Addy, which is an oral medicine that you take daily, and those medicines work in the desire center of your brain, and but they don't work like Viagra in lots of different ways. One is they're not meant to give people an erection. That's what the Viagra is supposed to do. And there are products actually for women that have sildenafil, which is there's some topical things that can help with vasodilation of the clitoral vessels, but they don't work the same way in women, unfortunately. So the medicines that are centrally acting for women that it's funny when I heard the statistic, because when we think about things that work in the brain, whether it is medicines for depression and anxiety, they typically work in about 60% of people. That's what they could think is successful. So like if this medicine works for your depression
Mm-hmm.
in 60% of the people that tried it, they're that, but
Mm-hmm.
these medicines, they're not going to be perfect for everyone, but they can help with about 60% of, and you just have to try these different things. So some people are like, oh my gosh, I could not live without my testosterone. I went on it and I feel like $1,000,000. And then other people are like, it's still not really happening for me. And you have to say also, are there maybe some other parts of that biopsychosocial part of your sexual function that are not supporting that? So there are medicines for low libido in women. They don't work for everyone, but do you
Mm-hmm.
deserve to have a conversation about whether those things might be helpful for you? And because there are some things out there, and we hope as women's health gets more money put into research, which is like, come on now,
Mm-hmm.
that we'll get some more products that will be available. And we're hoping to get a female dose testosterone within the next 2 years. So that will be helpful too. So
A friend of mine started testosterone. She loves it. And she is like, the gardener comes over and she's like, I'm looking sideways at him out the window because her desire has come back, like she's like
Mm-hmm.
yes.
getting excited. And she has said it has been really effective for her sex drive. So that's interesting that the conversation continues with testosterone. So it looks like we'll be seeing some new developments in these next coming years.
We hope it is something that's actually sort of crazy that the FDA has not moved forward with approving a FDA a dose of testosterone for women, because they don't think it's safe, even though we have tremendous safety data. Women have been using it for many, many years. And we know that it is safe because we use it in much, much, much higher doses for women, for trans men who are using that. And we know how it works. If they're saying we don't know how it works in women, when we use it in trans men, that is what we see at much, much higher doses, and we know that it is safe. So it has been a little bit crazy that we haven't had more movement from the FDA on approving it. And one of my mentors, who I just think the world of, who's a big researcher in sexual medicine, Jim Simon, said he was actually in a meeting with the FDA, and he was talking about getting these drugs approved. And there was actually someone from the FDA and who said, well, this is not really a priority because women don't have to have an orgasm to have sex. And that was a woman from the FDA.
What?
Yes.
Oh,
I shouldn't have probably said called it.
my
But
God.
but so they're like, this is just like, oh, well, yeah.
Now everybody's Googling FDA.
Yeah, right.
Right.
This was a long time ago.
Yeah,
Because
yeah, right. What government function would not want increased women's sexual function?
it is,
or
it's kind of
well,
crazy. But
it is.
but yeah, I think that the main thing
But
is
that'll turn around. That'll
that
come. That'll
you deserve to at least have the conversation. And there are safer and less safe ways to deliver testosterone. And there are definitely side effects that you potentially can have if your levels get too high. So you have to go to someone who is doing it responsibly and checking your levels and making sure, because you don't want hair loss on your head. You don't want hair growing places you don't want to have your voice change. You don't want to have like acne. So you have to you have to use it.
Nobody wants hair loss.
No.
Yeah. That's already coming with perimenopause.
Yes. And again, there are ways of managing
Right.
that too. That's a whole nother conversation. But
Right.
so yeah, it is reconnecting and seeing which part of it is, if it is just the desire, is it desire that's biologically mediated, or is it the loss of
I
intimacy?
think you're hitting it on there, because so if somebody is listening to this and wanting intimacy and sexual activity and so forth back, there's a few starting points, and you're exactly right. Would it be physical? I mean, is there a problem physically? Am I depressed? Is it closeness?
Is it that I'm just not sleeping?
Is
And
it I'm not right.
my
And so
sleep
to
disruption
find, we're kind of jumping all over the place, but but we're hitting on all the points, and to find your starting point, to find where it is that you are. Wow, if I start on this path, then it will lead the right direction. Is a Yeah, it's really important in how quickly this can turn around. And you take something just as simple as couples counseling. Man, you talk about that is the type of counseling that gets the most results the quickest.
Mhm.
I mean, you'll hear about folks that are going to individual counseling for years. And you'll hear about some couples, but it's more of a maintenance, it's more of a checkup, it's more of an oil change, it's more um, but gosh, there can be a lot of work done pretty quick.
I feel like too, women in midlife and just from talking to other women at this point in life feel stuck. Like they're like, oh, like it sounds like, I've got a plan or I've talked about this, but like I can't even just make that first step. So, what kind of advice would you guys give to them if they feel stuck? They want the change, they want it to happen, but they don't even know how to do it or where to start or where to begin.
From the sort of other side of the coin, I have a big group of lucky to have some good friends in town and so forth. And let me tell you, 6 months ago, if you had told me I would be giving talks on menopause, that probably wouldn't have believed you. And again, it's not me, that I'm more talking the everyman and the couples part of it, but so many of them, even though everybody made fun of me, so many of them have come to me and said, and they'll come to me individually, and I mean, it'll be in a bar or something, and they'll say, "Hey, listen,
He has time to go to bars.
oh yeah, and watch Phillies games."
Lucky him, gosh.
Yeah, I wish I had that time.
Yep.
Anyway, back to me. The no, but people will come. They'll come up to me and they'll say, "Hey, my wife is da, da, or my wife's having pain with, or da, 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 or is there something that can be done?" And both of them are afraid to ask the question. I mean,
Mhm.
and so where to go first would probably be the uh, the answer. And I would imagine your physician, and
Yeah,
just to
well,
kind of
yes, you would think, but I have seen many, many women who have gone and it's been dismissed. I had one person who told me that she went to a older male physician
yeah,
who,
you're right.
and she was having pain with intercourse. And she needed, she asked him
Oh god.
about vaginal dilators, and he said, "Well, your husband's walking around with a vaginal dilator in his
Yeah,
pants
yeah.
every day."
Oh my god. No, no,
And
no.
so that kind of dismissing it, it's hard enough to bring it up, but the fear of being dismissed
Mm.
is horrible. And so there are a couple of places that you can go for more reliably be able to get someone who is educated in contemporary menopause care and
Mhm.
sexual health. One, it would be the Menopause Society website for look to find a provider.
Mhm.
The Menopause Society is people who've done extra education specifically to address menopause. And then the second one, and I think for sexual health is even better, which is the International Society for the Study of Women's Sexual Health. That is the organization that does research, promotes research and evidence-based care is the International Society for
Mm.
Study of Women's Sexual Health, which is ISWICH, which just, super rolls off the tongue. ISSWS And so that you and get find a provider, but they also have
Mhm.
a site that is for patient facing education called Prosela. Again, I don't have no idea what that name comes from, but but the ISWitch will is a really
That's a
good
good starting
resource,
point, yeah.
and it's gonna and they have people that are gynecologists, pelvic health, sex counselors, all of these things. And then if you're looking more for a psychologist, actually, don't you think like Psychology Today, believe it or not, has a
Mhm.
website and it's very helpful of putting in what you're looking for. So if
Oh,
you're
it
like
is. It's
looking at
great.
for OCD or
Mhm.
you're looking for the that eye movement kind of what is that?
Yeah, or
Whatever
testing.
you're
Yeah,
like,
yeah.
then you can say, okay, I want someone who's doing couples therapy or sex therapy, and you can find that
Yeah, it
resource.
narrows it down, and every psychologist and psychiatrist are on it, or on
Overall.
Psychology
Mm,
Today
yeah.
because yeah.
So trying to find
It's the
the
Google.
resources that when you don't know where to start,
Right.
those would be some places where you can say you don't have to do it on your own. You don't have to figure it all out on your own. There are people that can help you with that and try to figure out what are the right hormones. Do I need hormones? Do I need something different? But
Mhm.
that's it.
Yeah, yep.
Yeah.
You're like, that's it. That's where you go.
That's all I have to say about
Yes.
it.
Oh, yeah.
So let's talk fantasies because fantasies are a big part of intimacy and sex. Everybody probably has some sort of a fantasy here and there. Um, do you think it's a good idea for couples to share fantasies with each other, or is it better to keep it a mystery?
Mm.
So to talk about them with each other, their
Yes,
fantasies? Mm.
correct.
Oh, no, absolutely. Yeah, I mean, communication would yeah. I mean, that, um, I eh, eh, well, in talking to a lot of couples, um, it's it's amazing how simple sometimes some of the fantasies can be, and they have not shared it. They just they haven't shared it with their partner, and so, yeah, I mean, you're just kind of adrift.
If
If
if you
Go.
wanted those things, you're talking about I guess there's different types of fantasies that you because there's ones that can be realized
Mhm.
with your partner, and then
Mhm.
there's things that are going to be things that are not um that don't involve your partner. And so and I would think that some people not be may feel threatened by that. There may be some
Oh,
that
okay. Yeah.
oh, I always think of my ex-girlfriend when I'm having sex with you.
Yeah.
That's probably not what
You
you want to
well,
share.
You're right.
yeah, I would be careful about
Yeah.
that. No, but yeah. But if it's, if it's, I've always wanted to do it at the beach or something like
Mhm.
that, then absolutely you gotta let them in on that. But the thing is that with a couple, I think that most people have a pretty clear line of what would be crossing and what would make them uncomfortable or what would hurt their feelings or what would do
Mhm.
something like that.
Yeah,
Yeah.
and I guess it's something you can pick and choose those things.
So sharing to a point. Yeah.
But I think that one thing that we see that's an important tool for in midlife is you do when you lose your estrogen, one of the things you lose is that dopaminergic control of executive functioning. So people that have ADD before menopause, it increases by about 60%, which is horrible. And then if you didn't, it increases by about 30%. And so when you look at one of the things that's really interesting, just being nerdy like this, is that when you look at functional MRIs where that light up different parts of your
Mm, mm,
brain when they're
mm,
stimulated. And if you look at ones, because they do this where they have it where people are having sex and in an MRI machine,
mhm.
which who doesn't have that fantasy? But they have that. So
Yeah.
when they light up during sex and then in orgasm, you cannot have this part of your brain, the frontal lobe, which is in charge of keeping everything organized and executing things, has to go completely dark to have an orgasm. When you look at it, it's like not funcking.
Which
And
is why it's so easy for men.
yeah, that's right.
Our brains just stop it.
There you go. You said it.
Yeah. So if you are someone who is struggling with controlling and that part of your brain is just firing off all the time, then it is going to be harder for you to have an orgasm. And that's part of why, so one of the reasons that women can find it harder to orgasm in midlife. And so one of the things that we talk about is how to override that. And I promise I'm bringing it around, is that some sensate focus, which is just concentrating on the sensations and focusing on the sensations is one way, but also fantasy can also be an important tool for midlife women to use when they are in the midst or trying to focus on to get to orgasm, because that you need to occupy your brain a little bit and get it to focus not on, do I need to pick up the dry cleaning, or you need it to focus in on something that's internal to the situation so that you can actually get to orgasm. And so fantasy is an important part of midlife sex. And whether that fantasy is something that you feel comfortable sharing or not, or if you're like, I'm just going to keep this because it may be like, I'm not thinking about you at all. That may not go over real well, but it is, I want to be intimate in this moment and it's hard for me to stay focused. And that's a whole other thing. Anyway, so that's my take on that.
When we're going into our OBGYNs and our GPs, are there any tests that we should be asking them for, that we could test our sexual health and, from that end? Are there any specific tests that we should be asking for?
Well, there's a few things that come to mind that it's just that you really need, if you're having any pain or you're feeling it, they really need to look and try to help you figure out, where is that pain coming from? Is it just superficial pain because you have a little, that you need some estrogen, or has it, a lot of times you'll have that if you have any dryness, even intermittently, your muscles are like, well, keep that thing out of there. And so you get a lot of muscular hypertrophy where the muscles cannot relax. And so people are like, well, I'm using lube, but it feels like he's hitting into a wall because the muscles of your pelvic floor are so tight. And so you need your doctor to be like, okay, is this just a superficial problem, or do I need to see a pelvic physical therapist to help with a muscular problem? And so that's the first part. It's just, and what's going on with the clitoris? Can you even see the clitoris anymore? Is the clitoris so diminished that maybe I need a little estrogen, testosterone to around that area to try to help with that? Are there adhesions around the clitoris? A lot of people aren't even looking at that. And they say, if you've lost your orgasm, that can be part of it. It just can be that the clitoris is diminished, or it's adherent to the tissue that it needs to be freed. So then we go into, and then to go in it a little bit further, you can get your test your testosterone level, and there's no testosterone level that's like, this is exactly where it's supposed to be. But if you see that it's undetectable, I mean, I'll test people's testosterone and it'll be like, okay, well, you have essentially none. I mean, so then that way, like, okay, well, maybe this would be helpful. It's at least something we could try.
Right.
And just, so that would be where a testosterone and sex hormone binding globulin, which is another thing that's too complicated, but needs to be tested as well. But it binds up your circulating testosterone. So even if you have testosterone, it can't fit into the receptor. It's like it's wearing a sock. So it's like, and so those things can be helpful to try to see if it's a biochemical problem is it a structural problem? And so I think
Yeah,
that's it.
and so and back to what you said about make sure that you go to a doctor that knows to test these things,
Mm-hmm.
that is familiar with all of these.
Yeah, that's one of the craziest things is that you go to a doctor sometime and they know nothing. Like an OBGYN sometimes knows very little about menopause and really to no fault because in med school it was not really taught when they were in med school, was it?
We just hired the most lovely new resident and for our practice, and she is delightful, and she's fantastic surgeon, and she is an amazing obstetrician and delivering babies. She could take care of any high risk thing. She knows almost zero about menopause, so she's always coming down the hall to me and be like, "Hey, I have this person. Can you teach me about this?" And I'm happy to do it. In fact, she actually had a baby 2 days ago, and I brought her a little packet on menopause for her to look at while she's on
So
maternity
they're
leave.
reading
She's like,
material.
she's like, oh, I was
Yeah.
expecting like maybe a cute blanket, but thank you. I'll take this packet on menopause. So this is a person who just finished residency in July, and from a very good training program, but it is a lot to pack in, and it's so much more nuanced. Wait, if there's a bleeding uterus and you take it out, it stops bleeding. So you've solved that problem. But it's so much more nuanced to teach people about how to take care of menopause and perimenopause. It's really, you can't do it in one lecture. You can't do it I went to ISWITch, which is a really fabulous learning society. And I went for several years before I felt like I was even starting to get capable of treating my menopausal patients.
When Kate took that pamphlet on menopause to the doctor she handed it to her and then also made her cut off the Phillies game so that she would read it.
Yeah, don't pay attention to this cute baby. I want you to keep studying.
Now's the time for work.
To be fair, it was just coincidence. I had that packet for her already, but I was like, since I'm here.
Yeah. Here's your
Just a little light reading. It's fine.
Here's a little reading. Yeah, that baby's gonna be asleep in a good bit of the time. So, and you don't need to sleep when the baby's sleeping. You need to just be studying.
Go to somebody that knows what they're doing. Yeah.
Mm-hmm.
So
Absolutely. I think to women, because our bodies are changing so much, like physically, just the appearance of our bodies, that also becomes such a mental block with sex and like intimacy too, because you kind of look at yourself and you're like, this is not my body. Like this body is like different than when I was in my 20s and 30s and even early 40s. So what do you say to those women that feel like the loss of confidence even within their body to kind of put it all out there, even with their partner?
I have asked, it is funny. I have had women complain about in therapy, and with the guy sitting right next to him who's just holding up his hands and saying, I like the way you look. I don't know what else to say. I like how you look. And we were talking with on another podcast, a comedian that's our age, and he says, well, he was on the algorithms of dating websites or whatever, where it was sending him 20 and 30-year-olds, and he just kept flying by him. And then when it was somebody 50, that was he stopped. And so I think partners, as they get older, also like somebody the same age. I don't know. I mean, speaking for men, not all of them, but I mean, it's going to be, yeah. But to have the confidence, just confidence itself is sexy, and to maintain that. And a lot of times, again, guys will feel helpless because, wait a minute, I like the package. I like how you.
Well, I go back, one of the my favorite old country songs with now I guess it's old, but Randy Travis had that line in one of his songs that said, I didn't fall in love with your hair, right?
Right.
So that, and it's, if it is something that is forever and it's not the person, you're not in love with, if you have a role or not, don't have a role, or what's appealing to you or not. Most of us are looking for connection from sexual activity. You're looking for endorphins and release, but you're looking for connection, and that body confidence is an important part of your own libido, especially for, but understanding that your partner is really looking for that connection,
Right.
not necessarily for just the visuals,
perfect figure or whatever it is.
And but it's a whole lot of changes. And if I have patience,
we like a little patina on our precious metals. Feel free to steal that one.
Good point.
Yeah, that's right.
I will.
Exactly. Oh, patina. So it is that, but losing that confidence, and you're not who you were, and you're not you look at yourself, and you can be very judgmental. I'm actually working on a program for women for body confidence, because it is this time you do lose that body confidence, and reconnecting with that is really important. And how do you get back to appreciating what's going on in your body, and appreciating that is the beginning of confidence.
Yes.
But it is a pain when you have to buy new jeans, because it's just a pain. Nobody likes to buy new jeans.
The weight shows up in all these crazy places, it's like,
my mom called it the shifting sands of time. Yes.
So poetic.
Yes. Yeah. But it is, she's like, I weigh exactly the same. It's just not in the same places.
Yes. It's true.
But the metabolism definitely changes, and it's and it is, and that can't, estrogen is, I will say that estrogen and progesterone and those contribute to those changes, but they so helping to get the estrogen, low estrogen can contribute to insulin resistance, and there's a whole feedback system that goes into that. So people are like, now that my hormones are back where they were, why am I not losing all this weight? And it's because you get estrogen and progesterone and testosterone are not weight loss medicines. They can help to stop the changes in the metabolism that you have, but they're not necessarily going to help you lose weight. And so it will have to be looking at other increasing muscle mass, and God, like, yes, I hear you, eat more protein, but like everybody's like, but it is, for us to reset some of that set point, we have to increase our muscle mass, and try to, and so that's why the resistance exercise, if you do choose, or you are able to do, or hormone therapy, or if you choose to, then that can be part of the toolkit of getting metabolism back. But it's only one part of that. And if you can't use hormone therapy, or you choose not to, it's okay. You don't have to. You just need to know that you're going to have to address your insulin resistance and glucose metabolism and those cholesterol changes in more aggressive ways, and use other parts of that toolbox in more aggressively. So you're going to have to make sure that you build that muscle and really get to the point where you are increasing that metabolic set point.
I'm glad you said that, because I think that's a big myth that's floating around, is if you take HRTs, you're going to magically start losing weight.
It can help for some people, but it is not necessarily going to be the magic bullet. It's not the same as taking something that actually is changing your metabolism. And there are things, the GLP-1s and things like that, that are going to help to change that metabolic set point. and really shift how your body is metabolizing. Should everyone be on a GLP-1? No, they shouldn't. There are lots of ways, but it is one tool in the toolbox of trying to deal with the metabolic changes that we have, and that are going to affect all of us, because men and women have metabolic changes at this point and that are going on, and we are not slapping an estrogen patch on him.
Right. Well, it's often women care more, or seem to.
Mm-hmm. Yeah, but it is definitely just, it's only one part. You can't outpatch poor diet or change it. The changes that, and then sometimes they're like, I'm eating less than I ever have. I'm eating more protein. I'm doing all the things. And you still may not be able to get the metabolism back. And so that's a whole other nuanced conversation of, okay, if I can't get it back with changing my diet, then where do we go from there? But I think that absolutely we know that estrogen it affects the gut microbiome. It affects the glucose metabolism and lipid metabolism. And so when you lose those, you're going to have to, in some way, address them in a different, or you're going to have, everybody's going to have that.
I'm nodding along as if everything she's saying is correct.
Yeah, let's hope it is, right?
As if I have any idea what this is. No, it is, but
let me tell you. I will say I'm studying for a huge test that I'm taking tomorrow. It's the American Board of Obesity Medicine, and that's why, because I felt like I had to know more about this. It affects my patients so dramatically at this point, and in the board, this is how the midlife women are treated. Okay, so one of the questions was, probably they're really gonna not let me be board certified for calling them out on this, but it says,
well, this will come out after the test.
Oh, good, that's good. So it says a 43-year-old woman, because you give your vignettes. So a 43-year-old woman comes in and she is having sleep disruption with intermittent night sweats, and she has these lab values, blah 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 blah, and it says what are the choices of treating this woman? It's like, add back hormone therapy, have her run more, or change her diet. And so then it goes, and the answer was have her exercise more, whatever. So, and add more protein, which is not bad. I mean, that's not bad advice. It's part of the toolbox. But when you go to the explanation of what below it, it says the average weight gain for women in midlife is between 6 and 20 pounds. And so this is expected weight gain. So you should not add back hormone therapy, even though we do know that it changes your glucose metabolism, because it is not indicated unless she has other menopausal symptoms.
So until she gains 20 pounds, we won't worry about it.
Or more
it's
than 20
expected,
pounds. And it's expected. And so what they're saying is, what other disease or metabolic state would they say, we know what will help fix this? Your thyroid is not working, and that's why you're gaining weight. But we're not going to give you back thyroid hormone because you haven't gained 20 pounds yet. Even though we know you're on your way to that, we're not. So if they know that this is impacts your metabolic health, but for some reason, the medical community has decided that it shouldn't be treated. But they don't do that with any other type of medical problem. They don't say, we're just going to sit back and watch this. We're going to let you have a little bit of asthma but not treat it.
Right. Or any mental health thing.
And watch you suffer,
And watch you suffer. Yes. Yeah. So anyway, sorry about that. Was a little bit of my soapbox on what you're battling out there. Because they're like, oh, well,
Yes. I'm glad you're bringing that up because I had Dr. Louise Newson on the show a few months ago, who's out of the UK, who's amazing. And she said the same thing. She's like, in what other world, yes, would watch a woman for 6 months suffer and not do anything about it or even longer, and just kind of watch, it makes zero sense,
Right.
So for the women out there that are listening right now that want to do like a change, like do something tonight, what can they do? What are like three things that they could do to help with their sexual health, their connection with their partner, the physical, the mental, emotional? What are like three key tools that they could do?
I think one of them's going to be sleep, but
Right.
the
Hallelujah.
yeah. Yeah. Just sleep, get enough. Um, no, I would go back to the intimacy all day, every day, and just the connection with if your spouse or if you ask a question, don't answer the question while looking at your phone. Don't be shy about a pat on the bottom or a rub on the back or a holding hands or a sitting next to, or the intimacy has to be there and be alive and be healthy. So that would be my answer.
Yeah. I think it would, if I would say anything, it's you just want to know that it's important. Just express that it's important to you. Say, hey, I know that I am struggling with I haven't been able to have an orgasm, or I am having some dryness. I I really want this to be a part of our relationship. And even if you said, just even saying that, like you said,
Mm,
any effort at connection,
yeah,
or and it is a tremendous step in the right direction,
right,
because just showing that it's valuable to them, but it's also valuable to you. And so
right.
that the fact that you want to even work on it is going to be a big step. But it lets you even say those words. And I think that if for women who feel like they don't even want to bring it up, because that's not, it could, it's a source of disappointing their partner,
Or themselves.
or themselves. Yeah, that it is just to say, hey, I know that we're not going to fix this tonight, but let's start looking into ways that we can fix this. Would be the first thing I would do tonight. And then I'd say, are you still watching the Phillies game?
Here we go. Here we go. Here we go.
No,
All right.
but yeah.
Full circle. Full circle.
Yeah. So just trying to
I need another drink.
invest in each other and invest in the relationship.
Yeah, no, it's a good point. And maybe even go in and see your doctor. Like go in and just have the
Mhm.
the
Mm,
full head to toe checkup. Make sure there's nothing going
Yeah.
on like, you know, in
yeah.
in the body itself, which is always helpful. So what advice would you guys give to your 25-year-old selves?
Mm.
Ooh. Um, Rogaine. No, I'm just kidding. I, I, God, that's a great question. 25-year-old self. Um, I would say, yeah, make sure that when you're 30, you reconnect with that Kate girl again,
That you met back when
that
you
I
were
met back
21.
when I was 21.
Yeah.
Yeah, make sure you do that. I think, man, that's good. Yeah, there's always things that you could have gone back and done better. I would I would tell myself that of all the things in with your spouse or with your partner or with your kids, um, my only regrets would be I didn't do some things with them. So I would have invited them more on, I mean, just trips to Lowe's, just time together. You don't get any of that back. And we did a pretty good job of hanging out together and having the kids with us and so forth. But it's, I would just go back and tell myself, man, if there's ever an opportunity to have them with you or to skip what you're doing and be with them, I would.
In terms of it being with a partner, I would, to my 25-year-old self, I would say that making sure that the things that, because when we talk about body changes and those things, that the person that you're with, look for the person who is going to, who likes the things about you that are never going to change. You mean, so you have to like about them, like you think of the person you're with and then think of them as having none of the physical attributes that you like. If the only thing you really like about them is that soul patch, then hopefully it'll still be there. But no, it's like, if the only thing you like about them is the physical things, then you say, okay, I those other things are going to go away. Who is this person?
What's going to stay?
What's going to stay? Yeah. And if this person, because just think of the person that's there, and then think about them, not, like 25, 30 pounds heavier. And the things that annoy you now are going to annoy you like 20 to 30 times more. And so if those things are not outweighed by the things that are valuable to you, then you need to just move on, because don't stay in a relationship that is not giving you what you need right now, because those things are going to get even more. We all become more of ourselves.
More of ourselves.
And I think that some of that does get stripped away in menopause.
That's good. Yeah.
It's so you become like a more crystallized version of you. So, and and I would say, do not ever drink grain alcohol Slurpees. Those are a horrible idea. Don't ever do that.
Don't do it. You'll see it the next day and it's not pretty.
It's awful.
That's horrible.
The mind eraser.
Yeah, it's a bad idea.
When the name of the drink is the mind eraser.
Yeah.
Okay. So solid advice from your doctor.
Right. Oh.
Right. How are y'all living iconically right now?
Ooh.
What does that mean?
Like what is our driving? So are we living? We're empty nesters. So we can ostensibly go and do anything anytime we wanted to. But we have to, we have a gimpy dog that we have.
We have a gimpy dog, and we have a whole lot of responsibilities that we've taken on at work. So we're living less iconically and more ironically. We have all the time in the world to do something we're not used to.
We're let's start new jobs.
Yeah, let's go
ahead and give ourselves 18 more things to do.
Yeah. Let's take a test on Saturday.
Yeah, let's get another board certification that you will need and does nothing to further your career.
Wow. Somebody needs a session.
That's right. I say, but the other thing I want to say to your 25th is invest in yourself, because investing in yourself and and invest in your relationship, because the more you put back into it, the more it's going to be there to support you when you need it.
That's beautiful.
Yeah.
Good. That's a good point. You guys are so amazing. You gave me so much good, information and knowledge. No doubt the women listening are going to love this. So it's been amazing.
I'm so glad.
Good.
Thank you guys so much for coming. Tell everybody where they can find you guys. I know you have a bunch of new projects coming up too, so feel free to share.
So we are in Charleston, South Carolina, but we're really most available as Heads and Tails.
So it'd be headsandtailspodcast.com.
Yeah. And so we're on Instagram and on the TikTok.
Yeah, and all the and you can type in Heads and Tails and anywhere
And
you
so
listen to podcasts.
everywhere
That's kind of the main thing.
Everywhere the podcasts are, Heads and Tails. If you put that in.
And to follow you.
And to follow me, I'm at Dr. Kate White, OBGYN, but you can also follow the podcast at Heads and Tails Podcast on all platforms. And he's at charlestontherapy.com.
So good. Yeah, I've been listening to your guys' podcast. It's so good, so informative. Yes, absolutely. So everybody should listen to it. You will learn so much about your body, your partner, communication, like all the good things. So, and I know you guys just got back from Dr. Kelly Casperson's amazing event. I'm sure it was great. So you guys spoke on the panel and everything.
So
it was fun. It was first class.
Yes, and her new menopause book is wonderful. But the New York, You Are Not Broken. If you haven't read her book or listened to her podcast, it is amazing, and it really addresses all kinds of sexual health problems, and so much information there. So that's great.
Great. Well, everyone listen to Heads and Tails. It's a great show. They're also fellow Southerners like me. We always love that.
That's right.
Thank you so much.
Well, take care. And we just had a great time.
Man, thank you.
Okay. I hope you're walking away from this conversation with more than just ideas. I hope you feel seen, empowered, and maybe even a little inspired to schedule a no pressure connection building moment with your partner tonight. Huge thanks to Dr. Kate White and Jay White for bringing the real talk, the clinical truth, and the relationship wisdom, along with the laughs and a few blush-worthy moments. If you loved this episode, do me a favor, tap follow on the Iconic Midlife. Share this with a friend who needs to hear it, and leave a review telling us your biggest takeaway. We read them all. You can find Kate and Jay at Heads and Tails Podcast. And of course, I'll drop all their links in the show notes. Until next time, keep redefining what midlife looks like. And remember, it's not about fading away. It's about showing up louder, bolder, and more connected than ever.